Okay, so I already preempted this a little bit. We're going to talk about the concepts of McKenzie. Just remember this. They're probably the most dogmatic group of practitioners you'll ever run across. And you'll kind of get a flavor as to why as we go forward. But the concept is pretty fascinating, pretty amazing, pretty cool the way it all came down. So that's Robin McKenzie, kind of right before he passed away. He was at combined sections, and he's got a really red nose, not because maybe he does drink a lot, but he's a big-time sailor, so he was always on the seas. And I'm not going to read this to you, you don't have to read this, but when you look at this, what he says, it's very similar to what you're doing now. It's kind of getting the whole picture, not pigeonholing yourself into one thing, knowing that you connecting with the patient is really important because the information they're giving you is going to help you treat them successfully. And learning everything about their life really helps you with that as well, particularly with this concept. So some interesting history about him. You know, he's from Auckland, New Zealand, and in the late or mid-50s, he discovered this extension concept. And I'm going to just fast forward for a second. This you can read later, but I'm going to explain to you what happened. Okay? He had a private practice. A patient he was seeing for about 3 weeks was non-responding. The guy had radicular symptoms and so on. And so he came in, he got there early. He told the patient, go ahead and go to that room, just lay down, face down on the table. And so what he was getting was, you know, your traditional treatments back then, some massage, some ultrasound, what we called WIFs, Williams flexion exercises, which is knee to chest. And he was not getting better, in fact, he was worsening. But the guy went into the room and the table was gatched up for the previous patient, who was in long sitting, and he laid prone in extension. And he had been there for quite a while, and when McKenzie came in, you read what that thing says, he was aghast. It's like, oh my God, and the guy's like, I've not felt this good in forever. And so, McKenzie paused. He could have said, this is like by total chance, and it was by chance, but the concept was born from that because the guy came back 2 days later and he basically put him in that position again, and all his symptoms went from his leg to the center of his spine, and then he started investigating this. So to give you an idea of how off the charts this, or not off the charts, how out of the norm this was, when I was a PT intern at Downey Freeman Hospital in LA, I had somebody doing extension exercises that was hospitalized in traction for low back pain. Okay? He had low back pain and he was in traction for 5 days. And he couldn't get out of bed. He was in so much pain, but it wasn't radicular pain. And I had him go prone, and I had him go prone on elbows, and he's like, oh, this feels pretty good. And then I went back later that afternoon and I had him try a full press up, and he could do it, and then get out of bed. I was so proud of myself. Here I am by myself on like the second week. Well, the neurosurgeon who put him in traction found out what had happened, and he wanted me to be kicked out of my internship. It was so awful that I had dared extend somebody, that you don't do that, it's bad for the disc, it's bad for the spinal canal, blah, 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 blah. And he obviously didn't know anything about this concept. But it's the one thing I kind of had some idea about when I first got out of PT school. And so that was what he was fighting against for probably 2 decades after he came up with this concept. Interestingly, in 1973, he came to Kaiser Vallejo. He did a 6-week immersion with Maggie Knott for PNF. And in return, he was teaching the PTs in Northern California Kaiser about his concept. And then because Maggie Knott had such a close relationship with Henry Kaiser, she was able to work it out so that Robin McKenzie would stay for 6 months and train all of the shipyard workers in this, how to take care of their own back. And that's, his notoriety started becoming pretty significant at that point in the US because of that very interaction he had with Maggie Knott, who hooked him up with Henry Kaiser, and I don't know how many people he trained, it was a lot. So, you know, after this, he kept kind of refining what he was doing, and it became the McKenzie concept. And he was going all over the world teaching, and now there are all these, you know, McKenzie societies. They don't call it McKenzie anymore, it's mechanical diagnosis and therapy. But it's pretty cool. And so if you look up the most influential physical therapists of the 20th century, he's number 1. And number 2, I think, is Stanley Paris. Number 3 is Jeff Maitland, and then it kind of goes on from there. But he really did revolutionize how you treat back pain. And Art White, who was a surgeon who also, you know, kind of took the spine conditioning stabilization concepts to St. Mary's Spine Center, also allied with Robin McKenzie and really said this is kind of revolutionary because there were a lot of people who had surgeries, particularly back then, that did not need them. So he changed that. And so this is a picture in his clinic. I don't know if this is the guy. Notice he's got some tidy whitey underwear on there. But that essentially is what the guy did. And so he must not have had horrible back pain, or he would never have been able to get in that position. He had ridiculous symptoms. So McKenzie's vision is that every patient he would see has the power to treat his own back, he or she's own back. And so when he started this program, it was like understanding the effects of movement on their symptoms in a meaningful way. Because, you know, I mean, physical therapists forever have said, what's it like with the flex and extend? And you get this information, it's like, well, what do we do with it? Okay. And then he really dialed in on the H&P, meaning the history and how it kind of fit with the physical exam. And he influenced Jeff Maitland to some degree because Maitland had his whole SINs and all that kind of stuff going. But as far as understanding why you do repeated movements and some of the combined movements that he did really came from his alliance with Robin McKenzie. And so the whole goal is to emphasize self-treatment, make it so easy even a caveman could do it. That's essentially what his book, Treat Your Own Back, does. It really demystifies back pain. And then the keys here are that you understand what aberrant postures or high-risk postures exist in the person's life that are going to either prevent or protract their recovery. And so that's why you dive into what people are doing. And I think what you come out of today is like a little more empowerment on explaining how important this stuff is. And then, so correction of postural neglect and really doing the right directional preference exercises are the 2 keys to what he calls reduction. We'll go through what reduction means in a few minutes. So I took a course from him. I just backed into it. I had just finished an internship at UCLA, and he was coming to teach a 4-day course. It was his level A, I think they called it. And he just had lumbar courses then. He didn't have all the C-spine, T-spine courses. And he was such a good speaker and very eloquent and taught everybody this. And nobody knew anything about McKenzie except for one person that was there and had taken a course, and that's how we got them. And he would just go all around the country at one point, and across Europe as well. So the practitioner who is trained in this model is, they know that self-treatment is the key to particularly ongoing improvement. no matter what you do with your hands. And they de-emphasize hands-on care. In fact, their hands-on care is, I don't want to say basic, it's maybe really, it's kind of brutal, really. They're very heavy-handed when they teach their hands-on care. It's not very specific, but you can kind of make that up as you blend it with some of the concepts we're going to go over today and on Thursday morning. So this dogma that exists is one of the things that is a knock against them. If you go to an AOMT course, there's a professor from, was at Damon College, I think, and he was at Tufts, and now he's at South Carolina, named Ron Schenk, and he has a manual therapy background, and he has a McKenzie background, so he blends them together. But most people who only have this training are totally hands-off for the most part, and it's to their detriment, because they could make bigger changes, faster changes if they combine the two. Centralization is the main thing that they're trying to reach. And centralization is unique to what they call the derangement category, which is a progression, the prolapse progression of the lumbar disc. It's essential to treatment. It's also essential to prognosis, because if someone has a difficult time centralizing their symptoms, or they can't centralize, then your prognosis is not as good. But if you can centralize them, it is a good thing. It's a positive predictor. And so when you think about what does centralization mean, it simply means pain in the extremities, or let's say you have broad-based low back pain. It comes back to the center. It's going, when you do a directional preference stretch, it's moving the pain back to the middle and the origin of the back, and then eventually it's supposed to go away. So when you do experience centralization, let's say you have extremity pain and you start doing press-ups to make a difference with this, or prone progression. Most of the time they feel pretty intense pain in the center of their spine, or near the center of their spine, and then eventually it becomes more and more central. If you centralize, like I mentioned, it's a positive prognostic sign, and then the centralization determines directional preference. So most people have directional preference with extension, the vast majority of people. About 10% of the population, depending, it's not necessarily anatomically dependent, it's just that flexion is something that helps them more than extension. And you can't always think about this in terms of a big fat protrusion or herniation or those kinds of things, because it doesn't necessarily always fit that. It can be nothing. You could have an MRI that shows nothing, but they still fit this phenomenon, okay? And so using precise movement, and usually it doesn't, like 80% of patients don't require much precision. It's like you progress them through an extension-based sagittal plane program, and that sagittal plane program gets most people there. And then there's a small subgroup where you need to add in side gliding and those types of other maneuvers in order to optimize the sagittal plane treatment, or the extension-based treatment. But most of the time, it's general. The goal, again, everything is for centralization. So this I already said, the directional preference, if you have radicular symptoms or referred pain, if it's not truly radicular, symptoms move from peripheral to central. If it's broad-based low back, it moves from that broad-based low back pain to more of a central thing. And many people will tell you, gosh, the center of my back hurts so bad, my back is so sore, but that you have to encourage them that that's something that is expected when you're trying to centralize something. And if they understand this, they're more apt not to quit the exercise because they realize it's a good thing. So it's something you have to explain to them. In the world of McKenzie, this is, again, the dogma of McKenzie, not of Robin McKenzie, but the people who are running this now. Centralization only applies to what they call a derangement syndrome, which is that disc problem, okay? And it can take a long time, or it can be something that you make happen in a single visit, where they centralize and then you talk them into continuing it and how important that is. Usually, pain will centralize and their symptoms are feeling better, but sometimes you don't get that right away. Sometimes you'll just see an improvement in range of motion. You'll see an improvement in side glide, extension, and maybe even if you test flexion, it'll be better. Less common, but you're really looking to improve extension in most of these people. And so the repeated movement aspect of this model is what's most important. And it helps you make a decision about directional preference, and it helps you make decisions about how you're going to progress them. In theory, this is the other thing where, you know, this whole concept has been proven not to be based off of a theory like this, but they're saying that you're changing essentially the nucleus pulsus' posture. You're influencing the posture of it, and I think maybe to some degree in a totally healthy person, if they were willing to have, you know, maybe a discogram or something, you might actually see the nucleus pulsus move more anteriorly. But in a disadvantaged disc, it just isn't the case. And there's been study after study now that demonstrates that that is not the thing. And so this is first a review that looks at outcomes. Okay, and does centralization actually make a difference in what's the predictive value of it? So this is a pretty large group of patients. You know, when you look at the total numbers, it's a lot. These are different, so they actually subcategorized it for good reason. And they found that centralization correlated with good outcomes and failure to centralize not. And this is a subacute population or a chronic population. So what does that look like? That means you have them do repeated flexion. It doesn't make them feel better. It might make them feel worse. You have them do repeated extension. It doesn't make them feel better. It might make them feel worse. And so there's no direction that really is helpful. And that includes side glide. So if neither one of those sagittal plane movements are helpful in your decision making, then you would do repeated side glide, trying to achieve the same thing if they have a shift. And so what they found was, by and large, this is what you would see. If you can centralize symptoms, you can give that patient, like, you know, a positive review, basically. This is going to get better. If it doesn't, it might just mean that you need medication to help you move over and beyond, or it might mean you need to do some hands-on care. And the hands-on care then will establish a directional preference after you've moved them a little bit. And it's also patient's perception of what's better and what's worse, right? And it's very, you know, important. That's a very important aspect of this. Stephen May, you'll see his name a lot on a lot of these articles. He's, I think he's located in Australia and is kind of the person who carries the flag for this group of individuals at this point. So this is a study that was produced and published in the name of, or actually no, Musculoskeletal Science Journal. And it basically looked at individuals with low back pain. Their ages were 30 to 56. So you have a good age span of people who have an aging disc. So it would be a 30-year-old with probably more fluid disc, and then you compare them to the person who were in their 6th decade of life, and it's a little bit less so. But what they did was they had them do 30 press-ups, and then they had them rest in prone and elbows for 15 minutes. So right away, you know these people are not necessarily severe, because they wouldn't be able to do a press-up or stay in prone and elbows for 15 minutes if they could. And then they looked at the posture pre and post of the nucleus pulsus, and they looked at fluid signal, and they had a computer that actually helped analyze the brightness of the nucleus pulsus. And they found that there was no significant differences in nucleus pulsus posture or vertical height. At AOMP, there was a presentation on patients with low back pain. I think the N was small, it was 15. And they had patients do sustained extension in standing, remember? And they actually demonstrated that there was an increase in the height of the intervertebral discs. I listened to it, I don't know how they did their measures, but the whole thing about trying to prove the mechanical side of this is really, I don't know if it's really important or not, because people get better. It's really the function that you should be looking at. And there's so many attempts at trying to say we are mechanically influencing the disc, and maybe they are, but I think after doing this for years and doing this on myself and having results that sometimes would be so quick, it's like, this is not influencing mechanical disc, this is not influencing certainly the free nerve endings, it's probably influencing the psoas length. Because just like you see muscle spasm on the backside in people with chronic back pain or acute back pain, you have the same thing on the front side. The psoas are not going to be like okay with the back problem. And so I kind of wonder if that's really what is happening. And you'll have to make those decisions for yourself someday. But that anterior side, it's, you palpate a joint, you have somebody do press-ups, and all of a sudden it just moves normally. There is influence on muscle tone, I think is what's happening. Okay. So this is another kind of similar study. They're just looking at the effect of, macro effect of disc pathology in patients who responded to an extension-based program. And there was no change in the features of the disc prolapse, yet these people were improved greatly. And that kind of drives that point home too, I think, that it was a nice way to explain it to patients. If you still want to use that concept, I use it now and then because you have to gauge, like you look the person in the eye, like, what's going to make you understand this? And so somebody who's more cerebral, you might not go through it, but I'll draw a disc out. Here's the nucleus propulsus. Here's what happens when you're in a flexed or horrible posture. That bulge gets bigger, and here's what happens when you extend and you press up through that. You're pushing that bulge back in. For some people that I don't want to say less intelligent, but they don't have the kind of reasoning skills that others might. It might really help them. Like, oh, I'm actually affecting this. And engineers, for whatever reason, they really grab onto that. So you can use that. It used to be like the jelly donut. Did you ever hear that concept? Like the jelly donut, the jelly squeezing out the back, and now you're pushing it out here, and it's going back to the middle. I think you could just draw this out on your whiteboard, have a little whiteboard discussion in your rooms, and it's actually pretty good. Okay, and so peripheralization, again, this is because of, in their world, it's because of a derangement. We know that it might not be a derangement essentially. It could be just a degenerative disc, but for the McKenzie world, they say, okay, if you have peripheralizing symptoms, it's because you're doing non-preferential posturing, mainly, and maybe movements. And so the biggest issue is sitting. And we always get bagged on, right, for talking about posture too much. I was walking through the medical offices yesterday, and who's the primary care doctor who's also a sports medicine doctor? He's Hispanic. I was so embarrassed I couldn't remember his name. I haven't seen him. Maldonado.
Yeah.
He's such a great guy, and he was walking around a candidate to come on board who's sports medicine trained. He goes, oh, this is our director of physical therapy. He's going to make sure you're standing up straight and sitting up straight. Oh God. Okay. And I mean, he didn't mean anything by it, but I'm thinking, this is our reputation, right? That's probably what the patients say. But I tell patients, hey, it doesn't matter. I mean, now is the biggest issue, but we don't know if poor posture brings this on. I kind of think it does. It certainly attenuates the posterior fibers of the annulus, but we can't say that because we don't have true evidence for it. But once you injure your back, It's the difference between getting better and not, particularly in a derangement category. So use it for patient education. Tell them, this peripheralization of symptoms is because of these things. And simple stuff like floating your head at the sky is a way to get kind of semi-neutral. And I used to tell Nicole this a lot, and I can't remember if it was tin or qua. It's like, yeah, but that's influencing maladaptive motor behavior and on and on. I'm like, yeah, Nicole, can you figure out what are you going to do to tell someone to sit up straight in 5 seconds? You can't say, well, this is how I want you to posture yourself based on you. If you float your head at the sky, it's a hell of a lot better than sitting like this. So that's why I do it, because it's quick and it gets them in a little bit better posture. But I think we'd all agree it's not the ideal way to do it. We just don't have much time with our patients. So using that verbal cueing actually can be quite helpful. Okay, so directional preference is a combination of postures and movements. Okay, it can't just be about doing press-ups, unless you're using your press-ups for something else. But the combination of these two things is aimed at centralization or alleviating symptoms completely, and the goal is improved range of motion at some point. Maybe not in one visit, but usually you see that. You see where you can get someone to extend either by walking them through it or putting your hands on them and then doing it. And so the lasting change only happens when they buy into the patient education side. So a real derangement. Think about your patients that have had a hot disc or a disc that's not getting better. If they're able to buy more into this, their chances are much better. The people that are a little bit harder to influence are those with a protrusion. Protrusions are contained, and they are out there, and they can be very hard because that annulus is hard anatomy. And if it's sitting on the edge of a nerve root, it can be pretty tough to kind of move them past that until they quell the inflammatory cycle. But all you can do is try. And so it's oftentimes, press-ups are what you want to get to. You may have to go with side glides first or a combination thereof, and then hopefully get around that. But the lasting outcomes really are it's completely patient dependent for those kind of individuals. So this is kind of an interesting study that was done quite a while ago. The second author, this guy Ron Donaldson, he's a neurosurgeon, and he practices I think he was in New Jersey, then he ended up in Virginia, but he had a number of patients who were going to a particular physical therapist, and he basically was sending them there pre-surgery, and these patients were canceling their surgeries. And he's like, what is going on? And he talked to the patients, and then he connected with the PT, and she told him, this is what I do. I guess it was quite a number of people who were saying, I'm fine, I don't need surgery. So he took the McKenzie courses way back in the 90s when McKenzie was still coming over here and teaching. And then he got certified as a McKenzie practitioner. And then part of his practice was being a McKenzie practitioner, and the other part was being a neurosurgeon. And then became a real ally of them to help research publications go to really good journals. It's kind of cool. But what they did here, Audrey Long is the therapist that was over here. I think she's from Australia, but then she came here to practice. That's how they met. But they have 312 patients. Okay, they have a pretty broad grouping of ages: acute, subacute, chronic, may or may not have radiculopathy. And out of all those, 230 of them, or 70%, had a directional preference. So good prognostic factor. Okay. They randomized the entire group into directional preference, into opposite of directional preference, or to nothing, to basic, I think it was a pelvic tilt or something. And so what happened was 30% of groups 2 and 3, the ones who went into the non-directional preference or basically no treatment, failed to improve or wanted to change groups. And then the remainder, those who did have a directional preference, largely improved significantly. And so this is kind of flies in the face of some of earlier research that said if you have a directional preference, it doesn't matter what we do, you're going to get better. So they proved that no, it does make a difference on what you do. And the difference is quite significant. Ron Schenk is the guy that was at Damon College and now is at South Carolina, and he does a ton of work with directional preference. He's published a lot of things. But what he did is he looked at patients who had who fit the clinical prediction rule for spinal manipulation. And so this was when there was this whole move it and move on mentality. If you're not manipulating the spine, you're malpractice. These are the kinds of things that Tim Flynn and who's the other guy, John Childs, were saying. They'd be up there, you know, at a keynote saying, pointing at you, if you're not doing a high velocity treatment on these people, you're malpractice. It was really kind of off-putting because they're really not, he was not an experienced clinician. He just was experienced in doing a lumbopelvic thrust. And so what they did is took that same group, they randomized them to spinal manipulation, mechanical diagnosis, and therapy, and essentially the results were equivocal. There were a couple people who came over from the MIP group to the other group, or 4 people, I guess. This is a small N, but the whole point was this flew in the face of what they were saying. And then Chad Cook had another study that they did and basically reproduced the CPR. Maybe you've already read this with Kelly and Ryan, but they did lumbar mobilization as you would as a clinician and proved that the outcomes were the same. So it was really, you know, treat the targeted joint, or you could do a general manipulation and the results were about the same. So you did not have to do a high velocity treatment. So here are your classifications. This is how McKenzie looked at the world. And when you look through this, it's a fairly pragmatic way of subclassifying our patient population. And you have to also realize that there's a blurred line through all of these, because many of our patients have a multitude of these things. If you look to the right, postural syndrome, a postural classification by itself is there really are no physical exam findings that support a problem that's, you know, stewing a pathoanatomical issue. It is, I sit for a long period of time in front of my computer, I get back pain, I get up, my symptoms go away pretty quickly, and you examine them and you don't find anything compelling. So I know that every one of you, if you palpated someone's low back, even if they were 14 years old, you'd find a stiff joint. Whether or not it's relevant is the other thing. But this is, yes, the longer I sit, the worse it gets. And the more I repeat this, the easier it is for me to become symptomatic. But the cure for me is to get out of the position and move around. Now, could this lead to a derangement? You betcha. If you did it long enough and you had risk factors for a derangement, you would probably end up with that quicker than otherwise. So the derangement syndrome is, you know, in their mind, it's an abnormal resting posture of the disc. The nucleus pulsus has shifted. It's not well distributed inside the annular cavity anymore, and it's in most cases shifted posteriorly. And so the belief here is that the episode will continue until the intervertebral joint has a normal resting posture. Now maybe it does influence it, we just don't see it on MRI. Maybe an MRI isn't sensitive enough. Who knows what's really going on, but you know it works. And then the presentations are, you know, very broad, and the classifications inside of a derangement are reducible and irreducible. And so this is essentially somebody that you cannot influence mechanically, that irreducible condition. Dysfunction is essentially adaptive shortening of tissue. So you don't believe that there's an active derangement going on, that maybe they had one at some point and now they just have a stiff back. Or maybe they had injuries when they were younger. I know you think about, like, you ask people, oh, what did you, like the other day or yesterday I asked this guy, did you play football? He goes, yeah, I played football in high school. In his neck, he's 40 years old, it's like, it's back there. I'm like, holy moly. And he's like 380. Like, I feel like I'm back in the training room treating this guy. I told Kelly my triceps were so tired. I was like chopping this T-spine and tried to manip it a few times. I'm like, man, I cannot get through to this thing. But he was so much better. Treated his T-spine and made him a believer that, yes, this is what you need to stretch. But he has a lot of dysfunction. Who knows what else he's done. He's a big, tough dude. He's a correctional officer, so probably other things too. But the etiology is trauma, inflammation that is unaddressed. And so you think, if you sprain your ankle, you're going to say, my ankle's stiff, I'm going to move that thing. If you sprain a joint in your spine, you have 31 other levels to kind of compensate for that. You don't see it, you don't feel it. So it heals stiff and can become a source of symptoms. And then aging. You know, as our beat up joints age, they move less, they start to become symptomatic because they're not moving and you don't have normal mechanoreceptor activity. Okay. So this is kind of funny. Pain is felt when imperfectly repaired tissue is loaded or stretched. So it doesn't tolerate being compressed. Maybe that's because the free nerve endings are sensitized because it doesn't move anymore, or stretched. And so these are patients we love to see. Because what do they need? Hands-on care, some guidance in prescribed exercise, maybe some therapeutic exercise. And usually their pain is associated with end range. So they flex forward, they hit stiffness, and they have pain. They extend backwards, they hit stiffness and pain, which is different than what you see in most derangements until they get into the reducible phase. And then in this group, but of course in this group as well, impaired neurodynamics is usually present. But impaired neurodynamics because maybe the interface is not moving well, not because it's got an inflammatory blob sitting around a nerve root, which is different than derangement. So the derangement in the McKenzie world is the most common thing that they see. Now, who knows what we see here? Well, I think we see it. It's not maybe the most common thing, the true derangements as we would know them to be, but we see the degenerative cascade more here probably. And so as previously stated, postural education is huge and it's got to be part of every treatment. And it's easy. It doesn't have to be complex. But it has to kind of identify, you have to say, okay, this is what I know your life is about. Like I heard Ryan Angels the other day saying, or yesterday, so you watch TV. How long do you watch TV? And the person said, yeah, I like to watch TV. How long do you sit in front of your television? And then they didn't answer. It's like, so, all day? And then he ended up, I'm like, yes. It's like, you need to get up every 30 minutes, period. And that's pretty much agreed upon by most people. So the two classifications you're going to encounter with postural neglect, both of these are influenced by it, both the derangement and the dysfunction categories. So if you think you're treating two things, what if you have somebody who has a long history of back pain, that's us, right? That's our groups. And they have an active derangement. You're going to deal with the derangement first. You might treat the TL junction, treat the hip flexors. You're dealing with that dysfunctional stuff to kind of optimize the ability for that person to do their home exercise. But the derangement is really what you're trying to settle because that's what's giving them their functional limitation or disability. So this, I don't know how helpful this is. I put this together a few years ago. I was so proud of myself with all the colors, but it's a rehash of what we just talked about. Okay? You have this, derangement that is reducible because loading strategies decrease or abolish or centralize the symptoms. Then you have a derangement that's irreducible, and that's loading strategy just doesn't help you. There's nothing that they can do actively or really with active movements or passive movements that you put them through that help them. So they're irreducible, and usually that's somebody who needs some medicinal help, or you need to coach them in how they get their inflammatory cycle to settle. And then you have pain occurring at the limit of range. Pain is equal to resistance. That's your dysfunctional patient, the ones we love. And then we have pain with prolonged loading. Physical exam is normal. And if you look at the bottom, they'll say, well, if you don't fit into any of these categories, it's got to be one of these other things. An SI problem, hip problem, a stenotic problem, instability. But people with instability oftentimes have a directional preference, and you have to be a little careful with that. Or chronic pain. So this is really all the McKenzie people talk about. After I took Robert McKenzie's first course, I took a second one from a woman named Barbara Hoyt, who was basically his American or North American continent advertiser, and she went out there and taught a ton of courses as well. And I realized that they don't really, they don't want to deal with this kind of stuff. Whereas we would, like, oh good, something different. But what I found very interesting was there was an old lady, because the cool thing about the McKenzie courses, they bring the patients in. They're like, please bring your patients in. They get them all lined up and they take them through. And for most of the time, you're like, oh, that's really cool. They make pretty substantial changes. But I remember Barbara having this woman, and they had, this was not at UCLA, it was at Huntington Memorial, and they had it in an auditorium, and there was a stage, and she brought the patient up, and they had this big floodlight on them. It was so funny. It was like you're on stage. I thought they were going to start singing, right? And so she is working with this woman and on the table, and over and over and over, and I'm thinking, oh my God, she's in her 70s. She's got to be stenotic, and she's pushing her into extension. And she just kept hammering away, and the lady came back, I think, all 4 days. And the last day, she said, oh, you look so much better, your motion's so much better, and people are going, mm-hmm. I'm like, I don't think so. She's still flat as a board in her, and she was having her do full-on press-ups, and her body was about this far away from the table. And then she said, and I think you're feeling better, aren't you? And the lady's like, yeah, I think so. I think so. And it's like, oh my God, you're just, saving face, but why would you do this with this lady? She didn't have a directional preference in deflection. So she just hammered away on extension. Now, some patients with stenosis, you're going to say, this is a stenotic patient, but they're actually doing really good with extension. You just do it and realize if they ever end up in the spine clinic with one of our PM&R docs, particularly if it's Ralph Chrysostomo, he's going to call you and say, why would you ever do extension with this woman? Because he's thinking extension in your average spine reduces the spinal canal diameter by 11%, and they're stenotic, you shouldn't do it. But then you can say, well, they're getting better doing this. I can't explain it. Maybe they're not stenotic. Maybe it's different. So, maybe the driver of their symptoms is different. The last time he called me, it was, I forgot who the PT was, but the person had neurogenic claudication symptoms that they were improving. I said, well, what do you want, Ralph? Reading the notes, the same notes you're reading. I said, I know, but I told her to stop those. I said, but she said, you wrote she's better. So why? He goes, oh, something's gonna happen. I'm like, okay. So I told the PT, call this lady and talk her off the ledge. And he had told her this is so bad for you. So it kind of ruined that alliance, but I don't know what happened after that. Okay. So the whole concept as you look at it is exactly what you've been doing. That's the cool thing. His concepts and what we've talked about with examining the lumbar spine is the same. The only difference is there's a significant reliance on repeated movements where we make a decision to do repeated movements when we think it's necessary. And so you'll probably do more repeated movements after we go through today and next time. But that's your decision. They do it with every single patient, and it's not needed. Okay, remember that, you don't need to. And so they would do this with a derangement, but you also do it with a dysfunctional patient, because if I bend forward and I have pain, and I come back up, and I bend forward again, I go a little further, and I come back up, and as I keep doing it, I'm getting better. You're like, well, that's a dysfunction. You have a flexion preference, but the rest of things don't look like a derangement. You're just stretching yourself out. Okay, so this is really primarily the difference, is the repeated movements in sagittal plane. At times, side glide, you may do repeated movements when sagittal plane movements are not fruitful. And so when Robin McKenzie taught this, it's a little different now. He would say you have to treat the shift. But the way McKenzie's disciples teach us now is, if they're shifted, you look to see if you can correct the shift. You get them prone and see if you can extend them. And what happens to their shift when they go prone? They might feel much better prone and they're not shifted. So you use that, and your hope is to get into extension completely, and then their lateral shift should correct when they get back up, or be better. And that's the way you're going to pursue it. So they don't really treat the lateral shift unless you don't have a directional preference, and that's when you go after it. And they would still do combined movements, but in there a little bit differently, not so much for pain provocation, but actually for help in treatment, and then sustained movements, same concepts. So the posterior derangement syndrome, of course, is the most common. And the typical pattern is going to be, for a posterior derangement, symptoms worsen with repeated flexion-based activities. And then extension helps centralize the symptoms. Now, for most of us, I think we'd all agree, we know that when we see a smoking disc, right? And I started, because when I took this course originally, everybody got repeated movements, and I made people a lot worse. Let's try repeated, you can't do flexion sustained, let's do repeated flexion in line. Keep doing it until they get worse. It's like, okay, now we're gonna go prone, and we're gonna see how you feel better. Well, that's not reality. You should, if you don't know what it is, then that's fine. But if you already know, based off of their history, and they're limited in extension, and they have a little shift, you can look at flexion 1 or 2 times, but you're going to go after extension because you know that's going to be the thing that makes them feel better. Later on, you can test flexion to kind of see if it's a sustained reduction, which we'll get into in just a minute. So there's an anterior derangement syndrome. I can't say that I've ever knowingly seen this, but it's pretty simple. They're not going to have radicular symptoms, obviously. They'll have maybe discogenic pain, so they could have referred pain into their extremities, but they won't have true radicular symptoms. And it's the reverse. If you see this, they're bothered by walking, and they feel better with flexion-based activities. But this, just because you see this doesn't mean they have an anterior disc lesion. It just means they have a directional preference in deflection, and you're going to use that. And it's usually only axial pain. It's not radicular symptoms, but not that they can't get a little bit of that. So just remember that, it's the reverse of what you see in the posterior derangement syndrome, and it might have nothing to do with having an anterior derangement. But if you look at MRIs, you'll see bulges anteriorly, right? Do the radiologists ever talk about it? No, because it's not heading towards any neural structures. But it could be if you have a posterior annulus that looks fine, it still could represent that this is a degenerative disc and it can be problematic. So when you have that person and they keep complaining about feeling worse with extension, look at flexion. Maybe that is the direction they need to go. Okay, big, nasty derangements. You've all had them, and they're irreducible, and they don't have a directional preference. So again, this is somebody who you might say, we have to settle you down before we do anything mechanical to make a difference. And what they'll recommend is kind of like, here's your management strategies at home. And it might just be a prone progression, something laying over pillows for a while, just getting in a recumbent posture that's good for them versus contributing to a worsening situation. But when you have stuff that's in the middle of the spinal canal, it takes a while. So these extruded discs, sequestered discs, they're not a long-term bad prognosis because the macrophages and giant cells eat them. It's the big protrusions that are still contained within the annular wall, barely, that really take forever. And oftentimes those eventually herniate and sequester as well. But once that annular material is exposed to the cerebral spinal fluid, there's a massive autoimmune response. And usually within 6 months, I have a case I'm going to show you, we'll do it maybe Thursday, 6 months later, the disc, you can't even see any fragments anymore. And it's not because it floated somewhere, it's just the body took care of it. Okay. So deformities, this again, the underwear of the 80s, I think is what you're being subjected to right now. But usually when there's a dramatic shift, you're dealing with a pretty severe condition. But we also have, the majority of our patients have some shift. We just can't see it with the naked eye. And that's why when we first started looking at lumbar spine, I said, look at them from the front, because you can see it from the front. The only thing is, you almost want to have their shirt off, because it's really, you'll see a shift in relation to the umbilicus. So if you're not comfortable having them take their shirt off, you might not see it, but you can hold their shoulders and have them scoot one way and the other, and you'll see a difference in quality of movement and probably pain provocation in one direction. Which is why it's always kind of nice to look at that shift, particularly if you're hunting around for symptoms. So there's the lateral shift, there's the focal lumbar kyphosis. So focal lumbar kyphosis is someone who's had a previous derangement. And because of that, they've had very selective, probably locking down the psoas in that area, and also probably some of your shorter rotatories and multifidi that just keep that joint stuck in a flex posture because it doesn't want to smash down on the annulus. That's at least the best way to describe it. And you'll see it. They tend to have a flatter spine to begin with, but there's also those people who have a normal lordosis, and you'll go, whoa, that is prominent, and that's something that's kind of stuck in flexion. And the best thing you could do for this person, if they're not acute, is to hammer away on that thing with PAs to help them get extended. It can be quite helpful. And then there's your patients who are locked in extension, which we'll cover in a couple minutes. But those are tough. Those are people who are stuck there, they bend forward, their lordosis never changes, and they usually require flexion-based treatment. Okay. So, reducible derangements. These are people who are responding to directional preference and postural cueing and education. Irreducibles, we've covered, but it is all loading strategies worsen or do not affect the patient, or they exhibit directional preference but symptom reduction is not sustained. So meaning you have them doing the right thing, they feel like it's the right thing, but every time they come back to see you, despite their compliance, they're no better. So that's still irreducible. And so what reducible means is that, and it usually takes a while, they get to the point where they're feeling better, they're maintaining their range of motion, and at some point you're making a decision to have them pursue their other range of motion that they haven't worked on in a while. So here's how you can kind of break it down. This is their 4 stages of treating a derangement. And it seems kind of, it's so basic, but it makes sense when you compare it to the soft tissue healing stages. Okay, and even though I think we all agree that discs don't really heal, it does get some fibrous tissues that heal over, and the inflammatory process settles down, and all of the muscle guarding settles down over time. So in the reduction phase, you're doing the preferential movements, the directional preference. You're making them adhere to postural cueing, meaning avoiding flexion-based activities, right? And then in their world, getting 4 to 6 encounters in like once a week, basically, to recheck them and make sure they're going the right direction is what they want. And the goal is to get them asymptomatic by the end of that period of time. And then you go into this phase, which is called maintenance of reduction. Okay, so they're there, they've got it. You tell them to start doing more physical activity like going for walks, but they are doing their reduction-based activities at the same frequency. And so usually, depending on who you talk to, it's 5 to 6 times a day doing press-ups or in some cases flexion, but they're doing it a lot during the day. And then you move into the phase of recovery of function. This is where, what happens with most people who are doing extension-based activities, then flexion isn't so great anymore. And you have to move them back towards that, whether it's using flexion in lying, or I like to do child's pose, like have them do a press-up, move back. It's kind of monotonous, but you go back into child's pose for 10 seconds, and back into a press-up, and they are kind of making sure they're staying reduced while they're reintroducing something that was a risk factor before. And then they move into prophylaxis, which is they continue what they did to get their reduction, but much less, like maybe once a day. And you kind of help them understand what's good for them and what isn't, and then of course they're exercising and doing all kinds of other stuff. So in the reduction process, and so when you think about this from the patient's side, they have to understand this because they're going to be waxing and waning in most cases. It's not going to always be a feel-good thing. In fact, as their range of motion improves, they're going to probably get more sharp pain, as we had kind of mentioned before. And they might drift in and out of peripheralization, and you just have to keep telling them that they got to stick with it unless the exercise is causing them to peripheralize. Then they need to stop it and call you. And that can happen. They start gaining range of motion and they start getting peripheral symptoms coming back again. And it might be for a different reason. Maybe it's not because they're having neural compromise, but the soft tissues are referring pain to the extremities, and you have to clarify those things. And then, this is kind of blaming towards the patient, but you can imagine you're trying to change long-standing behaviors. So if you have a directional preference that's working, you may have to re-educate them now and then and make sure they don't forget that it's not just about the exercise, it's also about how they're sitting, how they're standing, all those things that we know can make it tough. And then your chronic derangements, and these are people I talk to in the chronic back class, are really tough. They have a tough time kind of putting it all together because they also have neuromotor problems that others don't. If you had like a disc herniation today and I treated you and I went through this, your neuromotor system would come back by the time we get to the reduction period, and as you were moving through the rest of it to prophylaxis, wouldn't be an issue. But with the chronic derangement, sometimes you can't get out of the reduction period. It's an ongoing battle, and it's because they don't have, the whole system isn't working well together. So keys to maintaining reduction is things that you do every day. So one thing that McKenzie does, and you can agree to disagree if you don't like this, but they do a postural overcorrection. So I like to tell people to get up and move. But postural overcorrection is all of you are kind of slouching now, except for Tina. You close your head up the sky, you squeeze your shoulder blades together, you arch your back into extension, and you sit like this for 30 seconds. Okay, I'll tell you when 30 seconds is done. You keep sitting like that. Okay? We have 20 seconds to go. Yes. 15 seconds. This is easy to do, right? It's like getting in a military posture, except you're floating your head. Not doing a dorsal glide. Okay, and then you rest. And what you'll feel is like, oh, I'm sitting up straighter, at least right now. And the lasting effect is somewhere around 5 minutes. Also been studied by the McKenzie Institute. Like, what's the lasting effect of postural overcorrection? So they'll tell their patients to do this every 30 minutes. And the hope is that there's carryover, but they've never been able to show that there's substantial carryover. It's like 30% of people will have more postural awareness sustained over longer periods of time as they keep doing it. That's not for everyone. And then, the recommendations we give for optimizing our sleep postures, we know that to be very important. So people have to buy into it, and that's really up to you to convince them. I like this 2-minute walkabout. Get up and move. Walk back and forth in your office, walk around the hallways, walk outside if you're at home, set a timer, and then in 2 minutes, go back and sit down. And then if you want to do postural overcorrection, that would be awesome. But I think that's better to get up and move almost than doing the postural overcorrection. Okay, and then you're in the recovery of function. This is, like I had mentioned, adaptive shortening of tissues that are elongated with the movement you haven't been going for. There's also the fear of going into a flexed posture when you've been telling them, this is bad, don't go there, and people who really take that to heart are then fearful of going into flexion, so you have to help them progress to that. And so, flexion in lying is probably the first place to go. Again, I like to do the child's pose. I think it's actually softer, it's easier on the patient, and then go right back into extension. And so what they would do is do a bunch of flexion in lying, they test it, they have them do it as a stretch, and then they have them roll over and knock out their press-ups. But if you do one and then the other, I think that back and forth motion, even though it's a little more time consuming and a little monotonous, is not a bad way to go. Back in the 90s, Dick Earhart, who was one of the founders of AOMT, published a study on doing just that, press-ups, child's pose, in someone whose subacute low back pain began at N of 15. And then they did another group of spinal manipulation plus that, and the outcomes were more optimized. So, but this period of time, this is kind of, when we look back at this, like when are we hitting this? We're probably hitting it at the end of that proliferative phase of healing. You don't want to do it in the middle of it because that scar tissue is still trying to form. So somewhere around 6 to 8 weeks is when you're going to get into this. Okay. So your prophylaxis, it really is, you have to design it around what your patient's world is about, right? But there's no harm in continuing to do press-ups daily for most people. There is, when you get people who are in their 50s and 60s, they might be doing press-ups like a banshee to get themselves out of the acute phase and reduced and then over into the kind of the phase where you're going other directions. But then sometimes to have those same individuals continue press-ups to that frequency, it actually can cause symptoms. Because now they have been able to relax their musculature, they're getting more extension. When you start beating up against spondylitic joints, it can be not so comfortable. So having them do it once a day, like particularly like extension, flexion, nice oiling everything and keeping the extension is not a bad thing. For younger folks like you guys, you could do lots of press-ups and it'll be a good thing because you still have discs that are quite dynamic. So, but you have to, that's based off of your sins, right? You have to figure all that stuff out based off of the sensitivity and all that kind of stuff. And then of course, all the things we tell our patients, general fitness is really important. And then this, I think, if we could get all our patients to take these little breaks, you see a lot more, less protracted recoveries, but it's just not in them. And that's on us to try and use that for education. You guys doing okay or need a little break? You're okay. All right. Kelly, are you okay?
Can we stand for 1 minute?
Yeah, I think we should walk back and forth for 2 minutes.
Should we go walk up?
I'm going to do walkabout. It's really good.
Walk about.
Walkabout. Practice what we preach. Sit for a long time.
These stairs are quite treacherous.
What do you mean? Treacherous? They're designed that way for like challenging people's balance.
I was unsteady on my feet and stepped onto that. I was worried.
That's really weird. It needs a little block or something. Right?
Everything moves super fast. Tiles are so treacherous.
Oh, that would be very appreciated.
Do you want me to help you?
No, I don't know.
Sure about that?
No, surprise. I went to the Harvard Festival this weekend.
It's perfect. Nothing better.
They have a version of it at Starbucks now. Yeah, it's like a vanilla kind of mix that they can make. So like it's almost a mimic of Williams coffee that they serve. Because Williams coffee has like half a can of
Yeah, it's super sugar.
It's like,
Yeah, a lot of sugar.
There's a really good banana, oh, you have banana coffee, yeah.
No, the Philippines.
Is it stressing you out?
No. Yeah. It's a lot. Actually, it's all listening for me a lot of times. You know. How you feeling, Tina?
I'm so much better today than yesterday, thank you.
Good.
Yeah, I feel like I'm just more coherent, I probably filled the trash can yesterday.
Oh.
with all my fixes.
You filled the trash can?
Pretty much,
That's
yeah.
You mean
not-
with
it's
Kleenex?
not-
Yeah.
I gotta tell you, you've gotta use the pillowcases. You can,
That's nasty.
Reuse them, I mean.
No.
they're just-
Just
okay.
give one blow.
Like my grandpa?
Yeah. I
Why-
brought my own box of
why did
like
that exist?
special Kleenex
Yeah,
and
there's a lot of Starbucks.
I had a little station in the back office. Thankfully Lance isn't there because I could just,
Usually other places
you know,
haven't seen it.
have all the germs in there and sanitize and just.
But are you like way less pressure today because of
Yeah,
that?
yeah, today is, yeah.
I was telling Kelly that you can blow from your toes.
Yeah. I wanted to burst so hard that like it's so loud and then I gave myself that horrible headache at the end of yesterday because I heard too much. And I'm like, you know, yeah, so I think my problem is to be more gentle with this. And try to, yeah.
I don't know about that. I think I blow
For
as
that
hard as I
particular
can, get it all
thing.
out there. Bust a couple capillaries on the way out.
Right,
Plus
at
a
least
cat.
it was satisfying, yeah.
But the nice thing about the pillowcase is you can blow really hard and there's no collateral damage. You don't have stuff like on your shirt.
So you don't have a tissue,
like you
you're just
practice.
blowing straight into a pillowcase.
Yeah,
Wow, I never knew this about you.
yeah. No, I don't.
Maybe I'll have to
I'm not a
try
tissue
that later
person.
today.
I'm a paper towel person. But the paper towels we have here are so
Really
limpid.
rough on your nose.
Yeah.
So, It captures everything.
I'm sensitive. Even the tissues here.
And the tissues here smell like fish, so why would I use
And
that?
they're drier than the paper towels. They're
Yeah.
awful.
Yeah, that's why I brought my own box.
Yeah.
Oh, you
Smart.
Yeah.
My dad used to have Kleenexes, it was called Manly something. And they were huge and they were thick. They don't make them anymore, but that's
It's
bad.
bad for the
At
earth.
least you can have your own embroidered handkerchiefs or anything, right?
I have a whole stack of handkerchiefs.
Oh,
at
okay,
home.
yeah.
You know what it's for? It's for weddings and
Ah.
funerals. When the person next to you is crying, you say here. But I won't lie, I used to blow my nose in handkerchiefs all the time and
It
just
was
put
a
it back
thing.
in my pocket.
It was a
and
thing. My grandparents
Carry
did
my
it.
snot around all day. Yes,
Thank God for Kleenex.
yeah. Okay. So, the extension principle. This is what you're gonna mainly, and this is what McKenzie's associated with, right? Because nobody did extension, but it can just as easily be other things. It can be flexion, lateral flexion, it can be side climb. And so, as I mentioned, you always want to explore and use sagittal plane movement first. Don't waste your time, trying to get somebody's shift corrected unless they go recumbent and you can't get it corrected and it never changes. Then you have to go after it. The repeated sagittal plane movements, preferably in line. Not that extension in standing is a bad thing, but I know when I do that, and you get out of the car and you're like, oh. Well, but if you do it therapeutically, it's not that therapeutic for a lot of people because you're loaded. And which is why I don't understand why that case series they did was in extension and standing, but they must have had a reason for not doing it in line. You know what I'm talking about?
No.
Okay, you weren't listening. You were probably looking at your Apple Watch at the time.
What? What talk was it?
It was one of the,
Peanuts?
no, it was one of the platform research presentations. Yeah. Okay, so patients who stop responding to extension or worsen with extension usually need their side glide component treated. And we're going to talk about how that happens in a minute here. So here's some simple things. So if you have a shift that is not changing with sagittal plane movement and you think it is responsible for moving forward, then simple things like you're laying in hook line, you correct your shift, and then you allow your legs to move the opposite direction and you sustain that position for a while. And this is written in an upcoming one as well, but that can actually help change your shift so that you can actually progress your extension-based program. So you would do that a few times before you extend, and then eventually, in theory, you can move on and you don't have to do this anymore. There are other things like combined movements where you do your shift correction and then you do your press up. So this is an overcorrection, as you can see. So both of these can be used to kind of move on with your extension-based program. And then there's something called manual therapy. You could maybe try that too. This hurts, I move them, and now they can extend. That's what we do. But you want to give them something for home? This rotation one is actually a pretty good concept. So again, you're going to look at this and say, why are we reviewing this? This is so basic. But with the extension principle, when you look at the history, flexion-based activities bother them, extension-based activities make them feel better. So we would call that a discogenic problem, whether we think it's somewhere on the paradigm of prolapse, right? And then the physical exam, usually slouch posture. We see that in the waiting room all the time, don't we? You get out there and somebody's just horribly slouched, and that is always a challenge. So they have decreased postural awareness, their postural correction will decrease their symptoms. That's something you can sometimes do. It's really simple stuff. They have less lordosis in some cases, or if they don't, they have loss of extension greater than flexion, even if flexion makes them feel worse. Extensions blocked by pain, side glide might be minimally limited. And then repeated movements. Now what we experience is repeated extension doesn't always ease symptoms. It might make them feel worse, but it's centralization that we usually see. And so it may feel lousy, but it's a good thing. Okay. So your treatment planning can kind of be a myriad of things, but the prone progression, when we think about someone who is hurting bad, they come in to see you with acute low back pain, you might treat them, but and maybe you're not successful. They don't have a true directional preference, but you are saying, I think this is probably going to be the direction they need to go. You get them prone over pillows. And you can do this either on a video with them on their phone, or you can write it out for them. But they go lying over pillows, then eventually they transition to lying prone. And this is for little doses, 5-10 minutes. Then they go prone on forearms, prone on elbows, and then eventually they hit a full press up. And on Thursday, we're going to go over how to do a press up, because I am completely in disagreement with the way they teach press ups. I mean, it's always hands are in tight and their arms are bent part way and they can't relax their abs because their triceps and biceps are co-contracting to keep them there. It doesn't make any sense. And I can tell you that, maximizing the reach so they can get their arms locked out is really good. And then, if need be, in some cases, extension and lying with overpressure. So what you learn at a McKenzie course is you get over a segment that you think needs to move, they press up and you hold it down. And they are jamming into it. So they're doing the mobilization. They're just holding you an extension, or you're just holding them an extension. But it can also be, what about that person who has a little bit of extension-based pain at the end of range? They're athletic. You get them in this position. They're hanging out. You mobilize this painful joint while they're in full extension. That may be what helps get them to a pain-free situation when they're doing their sporting activities. And then there are these combined movements. We talked about that hook lying posture with a shift correct, prone lying with a shift correct with prone on elbows. You make it up as you go along. It is just, whatever their benchmark is at that time. Prone on elbows might be it, but you can then have them do shift correct there. And that gets them to extension and lying eventually, and then you might still need to have them do a shift correct when you get there. So there's a method to the madness. It's not as cookbook as it seems. And then there is their recommendations for manual therapy. And you can see I put, if you ever watch, what's the thing in the Saturday mornings? Football, Kirk Herbstreit.
Day.
Yeah, College Game Day. And Coach Lee Corso says, not so fast. These manual therapy techniques are barbaric. So the things that you've learned is what you can apply. But if you look at videos, extension GPM 5. They're just laying there and they put their hands across and go whomp into extension. These are high risk, you guys. And I think the only reason they do this is because they don't know any better. And this is kind of what was taught and they've carried it on. Ron Schenk does not do that. He's much more specific. And so these are the things that we can do in addition to press ups to optimize their extension-based activities. So then we have lateral shifts. So we're going to call it by the shoulders. And if you're Norwegian trained, it's the opposite of Australians and New Zealanders. So you just call it by the shoulders and don't worry about it beyond that. A contralateral shift is what we usually see. It's a shift away from the site of symptoms. But some people have a shift towards the site of symptoms. There was a JOS PT study that was published in the late 80s that was trying to predict where a disc lesion was based off of the shift. And so in their basic line of thinking is if you are shifted away from the site of symptoms, you have a posterior lateral herniation. If you are shifted towards the site of symptoms, you have a lateral herniation and you're trying to move the nerve root away from the lesion. And that did not pan out. In fact, I think it was a small number, like 20, but in most situations, they didn't even see a disc problem. So these people were shifted and there was no obvious protrusion or herniation, and there's only half that did have that. So there's no way to predict what that means. You just know that, you know, they're shifted towards or away. An unstable shift. Anybody see Bride of Frankenstein? So, what's his name? Marty Feldman. So you had Marty Feldman. He was the guy that worked for the mad professor the Frankenstein professor, and he'd had this big hump on one side, you know, like the Hunchback of Notre Dame, and then the next day it would be on the other side, and he'd look and say, wasn't your hump on the other side? And then Marty Feldman would say, what hump? So, just trying to educate.
I appreciate it.
That's a movie worth seeing.
I've seen that one.
It's pretty good. So unstable shifts are a bad prognostic sign. They just are. And you'll see them. They come in one way and then the other way. And generally speaking, that person, not that you give up on manual therapy, but you need to get them training. Spine conditioning, neutral spine stuff is the best thing for them. And they might feel better. You might manipulate them, you might have them do press-ups and they feel better, and then their shift goes the other way as they're walking out the door. It's really a weird phenomenon.
What would cause that?
Well, people say it's instability,
Okay.
but I don't know if it's really instability. I think it's just what their muscles decide to do in
Yeah.
the moment. I haven't had a patient with that in a number of years, but I do remember having a patient that just had a central disc lesion. So I thought, well, that makes sense. It's right down the middle.
Mhm.
I'm going to go over here for a while. That hurts. I'm going to go over here. So, and then you have people who have a fixed lateral shift. These are tough patients. I remember I had a patient who had it for 8 years. And I said, how long have you been like that? He said, let's see, when was the last Olympics? Wasn't that was the one before? That's like 8 years ago. Yeah, it's been about 8 years. And he was like over here. And he hadn't had any back pain until at that moment in time I saw him. And there was another spine doc that was here, and he was freaked out by it, and he wanted me to see him, and I saw him for a while, and I generally rotated him hard, like really hard. At some point I was getting up to like 15 minutes of a general rotation, and it helped his shift a little bit, and he was like, "Whoa, I feel so much straighter." I'm like, well, okay, I guess you're a little straighter, but it helped his symptoms. That was the main thing, but he still had his shift leaving here, and sagittal plane motion into extension was not an option. It was too painful for him. And I think he had a pretty large size protrusion that was calcified. So that was what was keeping him there, I guess. Okay, so just a little bit about when you're looking at side glide. The vast majority of side glide is coming from the last two segments, and that's why it's used. I mean, I don't think McKenzie necessarily knew that side glide was almost more than half of it came from the last two segments. That's not why he did it, but that's what you get. And with lateral flexion itself, it's really the upper lumbar segments down to L4 that does the majority of lateral flexion. So when you look at the quality of lateral flexion, you're really assessing those upper segments. And that's the only part of this I really wanted to share with you. It's kind of interesting. So the lateral shift principle is a bit different. And this is somebody who, again, they can't get sagittal plane relief. Okay, they present with a shift. You try to help them both actively and passively. And this is the person you might get in there and try to see how far you can get their shift corrected. But you have to be careful, because if they're really severe and you pull them into a position that brings on severe pain, they can get vasovagal on you. So you have to be prepared for that. And I think maybe doing the shift correcting in a recumbent posture to start with, if they are not corrected when they get in that position, is the next step. Because rarely do you have to really pursue this in the standing posture. And that was kind of what McKenzie was all about originally. You've got to get in there and jam them over. But really it is using the strategies that we talked about, the rotation with side glide, the progression into extension with a side correction, and then either helping them side shift or doing mobilization in that position, or doing manual therapy on them to move them on. Remember, all these things that we're talking about today are based off of a non-hands-on, there's no hands-on with this. And that's why these strategies exist. So, so these are options. So if you think you really want someone to work on, like someone that you're treating does really well in a recumbent position, but every time they get up, they slide back into their side glide, then maybe doing this against a wall is a good thing. You're just using motor control strategies now to offset it. Okay. This is the side glide with overpressure and overcorrection. And it's supposed to be a guiding force, but it also can be a very, very, very risk force. And you should be able to do this on someone. It's just not the first place you have to go. It's only after someone has demonstrated that they're not going to be able to use. So like that patient I was telling you about, had an 8-year shift. This is something you could do on a person like that, and realize you might not even get them, like him, I couldn't get to neutral. He just stopped. And there was no way to, his motor system was so programmed to keep it from happening that there was no way. But this will help you decide whether it's something you can even correct or not. Okay, so once you have a successful side glide, if you have to go that route, then you pursue extension afterwards. Again, you don't just finish with your side glide. And then your options are, and we'll practice this on Thursday, is correcting the shift and having them do a press up. Or having them do a press up and then doing a shift correction on them. Once they get into a press up, it's a little bit harder to do. It's easier to correct them and hold them there as they press up, but it still takes a lot of force, because you're going to feel that pushing back against you, so you really need to be over them and holding them tight. Flexion principle, we're kind of winding down here, but this is not something you're going to see a ton of. 7% of all derangements, whether they're posterior or anterior, have a directional preference into flexion. And usually it's people with low back pain only. And so I'm sure you can think about some of these people, and they tend to have a lordosis that they're stuck into. They just stay in that lordosis. And when they bend forward, they're limited in flexion, they have no unrolling, and it's kind of programmed. And so flexion is going to help these people a ton. Repeated flexion will help them a ton. It goes the full gamut from flexion in lying to using child's pose, flexion in sitting, which is more aggressive, and then flexion in standing, which of course brings in your tension signs a bit, and then flexion in lying with clinician overpressure. I don't recommend that you do that. but it's something that a lot of people do. They bring you up and they basically help you get into that flex posture. I think getting someone in quadruped and having them come back into flexion and then being able to work on them there is a really nice technique, which we're also going to do on Thursday. And then there's this, what you see here. This is a flexion in step standing. Okay? And it looks kind of like you're doing single kneaded chest, right? And so what's happening here is this is somebody who, in this case, flexes forward, deviates away from that side that they're treating. So they deviate towards a tension sign of God knows what. And so by putting your leg up here, staying midline, and reaching down and pushing yourself to stay close to this leg, you are opening this left side up. And so I think this is something that you can use for treating tension signs that are not resolving, that are dysfunctional. When you see that big shift over to the side, it's not a bad technique, and you know you're doing neuromobilization because this leg is straight and you're flexing forward at the waist, but you're also opening that side and forcing yourself to get over there.
So you put the leg up and that's away from, like
The
if
deviation,
you deviate away,
yes.
you put that, okay.
Yep. Okay. Okay, and here it is, kind of the indications and how you do it. I always wondered if this guy was Robin McKenzie's brother, because he didn't look exactly like him, but it turns out it's Robin McKenzie. I thought it was so funny, I'm like, it can't be him, but it is him. So, okay, and here's the technique that we were talking about earlier. You're shifting your hips. In this case, he's shifting his hips to the left. He's correcting his shift, and then he's rotating to the right. Here's some stuff based off of what the consensus says about the benefits of using this method. There's a few other things that I've thrown in here that are very consensus-based, but it's, you know, those who are greater than 40 respond really well to extension, but it helps you, you know, like for me, the last time I had really bad back pain and I couldn't walk straight up and down, I finally got myself pressed up. It allowed me to mobilize myself again. I was off to the races. But I never continue to do press-ups. I mean, I still do them every day, but if I did them 6 times a day like I had been, I would be miserable because my back just doesn't tolerate extension that well. And so you have to titrate things, and that's hard for us to do with the limited exposure we have with our patients. But that's what you would say. If you built a plan for them, it would be just that. It would be, you know, okay, once you are into the prophylactic phase, you're just going to do this once a day. So I had a patient a little while ago that came in for a knee problem, and her knee was swollen. She'd been playing tennis. She had bad patellofemoral arthritis, really fit, and she plays tennis, she rides bikes, she hikes. Those are her things, and she plays tennis just about every day of the week. And she's in her 40s, almost 50. And once her knee dried out, you know, I gave her just hip abductor strengthening because her hip abductor was really weak, and worked a little bit on knee extension. And then I said, you come back and then we'll see how you're doing. And I had some ideas how I was going to progress her. Her hip abduction's still the same grade. I get over to her back. It's like, okay, you're stiff at 4 or 5. She says, I've never had a back problem in my life. Had her do press-ups, 5 out of 5. I repalpated that joint. It moved perfectly. So there was an inhibitory cycle happening there, and so then I gave her a more advanced hip abductor exercise at that point, trying to integrate, you know, weight-bearing exercises with the hip abductors being turned on. And now she's back to playing tennis. And that was maybe, who knows, what came first, the chicken or the egg. Like, why would somebody who's really fit and strong and otherwise healthy, all of a sudden have her knee blow up the way it did. And her husband's an orthopedic surgeon, and he's like, just tell me, I could send her to this guy at Oakland, he can scrape her patella. And so nobody else will do that because they say she just needs a total joint replacement. Like, for what? And she told me, I'll just quit tennis. I'm not having surgery. But so it's little things like that that you might use press-ups for as well. It's pretty cool. It's like, okay, that stiff, I could mobilize it, and then she might be better, and I could say, well, that's what it is. But why don't I try a home exercise that might be something that will help her, and then I've already proven that that's all she needs. So, all right, I'm sorry I talked at you guys for 2 hours. Do you have any questions? I think this will come together on Thursday. I'll give you kind of a pragmatic way of looking at this, okay? And then we're starting shoulder Thursday too, after that.
So I actually have a question. So
Good.
basically it's a directional preference, right? And then favoring more extension. Let's say for McKenzie or MDT, if they had a patient that was more flexion preferred, do they have a model that they would just go towards in favor in terms of their treatment planning?
It's almost the identical thing for, it's the opposite direction.
Okay.
Use the same concepts of reducing, maintaining, and then reestablishing the opposite motion, and then finally prophylaxis. The only thing is that people who are truly flexion preference, getting them into extension is a little bit harder. Sometimes you see extension. I mean, I haven't enough experience with it because I don't see that many people who truly have a flexion preference. But it's not like magic, like all of a sudden their extension looks so much better after they settle down. But, they say 7% of derangements are have a flexion preference. I don't know if I could agree with that, but yeah, but it's the same model.
Maybe those people don't come to PT because our world's flexion based anyways, so they do fine functionally and they don't notice.
Maybe. Yeah, maybe. I don't know.
Just stop walking so much. They're all right.
Yeah, stop exercising. Who told you to do that?
It's fine. That's what I wanted to do anyways.
Yeah.
I'm lazy.
And many of our patients that we get, people who are really out of shape, don't exercise at all, and now they're on a walking program. And those are people who have some flexion preference because they're overweight and their facets are weight bearing a lot because they're pulled into an extension posture when they're walking. And I still don't get it. I mean, there are 3 people that walk in our neighborhood. We have a lot of people walking. I don't know about you guys, but after the pandemic, it's like, where are all these people coming from? They cruise through our neighborhood and there's a lady and then there's 2 men that walk like this. And I try doing this, like, oh my God, how can that be? And we see that with the way people stand, but when you walk that way, it's no bueno. And some people run that way. They run way back in their center of gravity. My friend Eddie Lopez, who I ran cross country with, ran like that. He was a really good runner, but I used to think later, like, wow, if you just got your center of gravity forward, you probably would have been so much faster. He was so inefficient the way he ran. So, yeah.
How would maybe they combine some of the other things we typically do, like all the lumbar rotations, all of those things? Would they go first, I guess more traditional McKenzie, do all their approach first and then maybe add those things in later?
If they think they need to.
Okay, so I guess with us we can just combine things as we
You treat your signs
normally
and
would.
symptoms and then you say, okay, this is what you need. But you can use this directional preference model with anybody who's a derangement or a dysfunction, and then you optimize mobility for them. You're basically setting the stage for them to be more successful with this concept. And this concept is money. I mean, when you're thinking about exercise prescription, yes, we do things, the lower trunk rotations and trunk rotations and strengthening, But when you look at sagittal plane movement, that's the biggest part of what we do every day. Our walking is sagittal plane, reaching, everything we do is that. So it's an essential part of what you should do with exercise prescription, for sure. And then when you get to the stenotic world, it's different. It's just you're probably not going to pursue this. But other things, like simple things like stretching the anterior hip musculature, might make to the other side of things. When they say somebody's not able to progress with their extension in line program. So they'll do side gliding, they'll look at all this fancy stuff, overpress the area. If you stretch their earlier psoas out, it's probably not going to hurt at all. And then they can be successful with press ups. You guys did that with Ryan the other day. It really is pretty fascinating. And I think we did that a little bit too before we did it with Ryan. It's like, okay, extension is so much better after you do that. Do you have to keep doing that? Well, maybe, or maybe you do that instead of press ups. Or maybe you just do the press ups now after you've established that or optimized that. But yeah, the real McKenzie practitioners are totally hands-off. And my daughter did a 6-week clerkship with a guy in Buffalo, New York, who was a McKenzie practitioner, and he never did any hands-on. And she said, a few times I said, can I mobilize this person's spine? Because when I palpated, it was really stiff and they're not progressing. He's like, no, just stick with the program. And she said it was like, twice a week they'd come in, and she said, basically I'm watching them do exercise and, maybe a little stabilization. And then she said, finally I just started mobilizing their back towards the end because I knew I was going to be gone. But she said, I don't think he was trying to show me like this, how the benefits of this. It was just like, this is how he does his business.
Makes it easy, you don't have to think much, right?
No, and he said 90% of people respond to extension. Don't worry about side glide, don't worry, And he teaches in the McKenzie Institute. So it's good, it's just, it's a tool you add.
I had a quick question. Have you had patients with inclusion body myositis? This was a new one for me about they had like a muscle biopsy. I'd seen him like a year and a half or two ago, and he was just weak in his quads, this gentleman, and he's getting into the balance group, but he's just had this progressive weakness, but no central neuro signs or things like that. And then he went through this, since I haven't seen him for a year, this kind of diagnostic procedure, and was diagnosed with that, where it's like this progressive, you're getting weaker over time. So he's looking into where he's going to live and maybe change his home setup so it's a little bit easier for him to be independent. So he's coming to PT, so we just got a baseline on everything of like, okay, these are things that would be good to gently maximize without overdoing it. And he joined like a support group, I guess. Pool therapy is one of the good ones. I haven't found a lot of research yet, but
it's a tough one because if they do too much, it sets them back for days or weeks. I haven't had any experience personally. I just know that it's not the first line of things you work up.
Mm-hmm. Yeah.
It's they look at all the different myopathies that people can have, and that's one of the more rare ones. Yeah. Although I think it's becoming more prevalent because they're testing more for it. Mm-hmm. Who else? Somebody else just had a patient with this.
Oh, okay.
Sarah. I think Sarah.
Oh, I'll have to touch base with her. Okay.
I think it might have been her. Yeah, it's not a good diagnosis to have.
And I think it was kind of dismissed for him because he's HIV positive, and they were thinking maybe some of this weakness is part of his progression.
So that would make it much harder to kind of.
So it took him a while to get diagnosed, I think.
Is it diffuse, or does it tend to settle in?
Diffuse for him, like one of his quads is just really tiny, no matter what he does, and then he's starting to get arm weakness and like finger weakness.
It's hard. You have a rash?
No rash. Yeah. He had like a bad strep throat infection like a year or two ago, and then I guess it could be precipitated by an infection, or it goes on remission cycles. What I was reading of like you can have a flare and then it will kind of calm down for a little while, almost like MS. It sounded a little bit like,
Huh, but it's a neuro, it's a,
yeah.